Dr. Larry brings you another segment of Did You Know?
We've all heard somebody say, I've got a bad knee. Or maybe we say it about ourselves. In addition, commonly in healthcare, there's a lot of chit-chat about that. We ache as we age and our joints begin to rage. And eventually, at some point, many of us will have to address some type of bone or joint issue, and you might be hurting so bad you need a Kleenex or a tissue. Because maybe you're the weekend warrior or athletic type, and after many years, you know that noise or pain in your knee just ain't right. So where do you go for a joint that's screaming no? Well, it's a field of choices, but when it comes to choosing an organization of surgeons for something as important as an artificial knee replacement, you want to pick a facility that has its processes and people operating like a well-oiled machine. And it's the style of this next physician owner at OSMS that makes him, along with his colleagues, some of the best. So pay close attention to this next guest. He's a practicing orthopedic surgeon who fixed a local lady whose knee already had one replacement surgery. But that's just the start of the story and will be the main focus of the show today. So for the sake of simplicity, we'll call this segment The Revision. Dr. Tressler, welcome to the show.
Thanks, Dr. Larry, for having me today. It's really exciting.
Oh, for me too. I've been talking to the public that you're coming on the show. And like I said, I think about half the people know you from the area. Of course, your dad being an orthopedic surgeon. And I've got patients that I've actually had surgery by both of you, which I think is kind of unique as well.
Yeah.
But let's get a few of the formalities out of the way first. Give us your full name, license type, and board certifications.
My full name is Michael Allen Tressler. I'm board certified in orthopedic surgery.
So it says it right there.
Yeah.
And just give us a little brief history or timeline of your professional career. What was, kind of how you came into orthopedic surgery? Just a little professional timeline. You went to undergrad, medical school. Did you always know you want to be an orthopedic surgeon? Just kind of a little timeline highlight for us.
Sure. I did my undergraduate training at Washington University in St. Louis. I always knew that I was interested in going to medical school. Kind of following in my dad's footsteps was my dream. And then I ended up going to medical school at Georgetown University, graduated in 1995 from medical school. And, in medical school is when you really start to see or decide. I mean, people have an idea of what they might want to be when they go into medical school, but you get a exposure to all the different areas. And to be honest with you, after the first 2.5 years of medical school, I really thought maybe I would be a general surgeon. I enjoyed the fact that as a general surgeon, you got to operate on multiple different organ systems, and because of that, there was just interesting caseloads of different things. I met an orthopedic surgeon at the end of my third year at Georgetown, Dr. Delahaye, and he made an impression on me that changed my mind. I mean, I always kind of had in the back of my mind maybe I'd be an orthopedic surgeon, but I had almost changed my direction until I met this guy, Dr. Delahaye, who he was just great. He made taking care of people fun, and I just learned a lot from the guy, and it changed my path. And then I ended up going into orthopedic surgery and following in my father's footsteps.
The rest is history.
Yeah.
So internal medicine doctor, I know his couple of kids are physicians, and he's like, none of them chose my field. They went off into other stuff, and I was like, it'll make you a little upset about that. The kids in the family said, well, my dad's a dentist. I didn't become a dentist, so don't hit your feelings, sir. But I'm sure dad's happy and proud. And how old is he now, though, by the way?
81.
Wow. Okay, enjoying retirement, I'm assuming.
Yes, he's still doing well, and we still get out together and do a little hunting and fishing together. And
yeah.
Yeah.
Well, you just said the two famous words for everybody in the UP in northern Wisconsin. Before we dive into this case, which, folks, it's a local lady, and you're going to find out why I chose Dr. Tressler to handle this very complex case. You're going to hear some of the details of the case, and we're going to get through that. But I had one of my patients, who's also a listener of the show as well, too, say, maybe you can do some Tressler trivia. So I'm going to do that based on listener request. What was your first job ever?
Well, my first real job was not by choice. I was more or less told that my dad found a job for me for the summer, in fact, for myself and for my brother. And he got us a job working on a farm that was just outside of Green Bay. And we picked stones, we baled hay, we didn't actually milk cows, but we painted a lot of heifer hutches and essentially, helped the farmer with whatever he needed help with, but mostly all of the kind of scut work, I call it, around that farm. And for anybody out there that's done any farming work, you realize that most of the work only happens on the nice sunny days in the summertime, and when it rains, you get a day off. So we used to pray for it to rain. We would be so psyched when we woke up in the morning and it was raining out and we didn't have to go to work because the farmer didn't have anything for us to do. So that was my first real job, and I was probably 14.
Okay. I had a guy come in, he's just graduated from tech engineering degree, and the reason why they hired him is because on his resume, he worked on a farm. And they said,
Yep.
You're an engineer, but you worked on a farm. Therefore, you know how to do things that sometimes people just need to know how to do, but you're already trained to do it. And I thought that was kind of unique. That was just a couple of weeks ago. This guy was in the office.
I'll tell you what, and I think this is why my dad got this job for me, because he grew up on a farm. And it was a humbling experience. I mean, I have all the respect in the world for farmers, because I'm telling you, I mean, we would be baling hay in this barn in the middle of the summer when it's 80 degrees out. And the top of the barn has got to be 90 degrees at a minimum. And you're stacking these 50-pound bales of hay, which I don't think they really stack bales of hay in the barn anymore. I think now it's all this these big rolls that you see out in the fields. But, we'd be taking turns at the top of the barn, and the conveyor belt would bring these bales of hay up there, and one 50-pound bale after the other. And by the time you're done, you've got so much alfalfa dust in your throat, you can hardly swallow, your tongue stuck to the roof of your mouth. And we would be, so excited by the end of the day, because you work hard. I mean, these farmers, it's real work.
Yeah.
So you gain appreciation for what it's like to do that kind of work.
Yeah, and draw upon that experience with what you do now, too, when a farmer comes in. Oh, yeah.
And we see lots of farmers because they wear their joints out.
Mm-hmm. Couple other Tressler trivia questions. Thank you for that. Give us one unique personal talent or your favorite hobby, pastime, or interest, and why.
Well, I think, as it relates to my profession, and I didn't realize this early on, but probably one of the strong points of my ability to do my job is that I do have lots of outside interests, and it has allowed me to really connect with my patients. I mean, you can be really good. You can be a really good surgeon, do a great job with surgery, and people are happy, but then they go out and they, 10 years later, and I see patients like this in the office, actually. I'm like, who did your other knee? And they can't even remember the guy's name, because you didn't connect with him. And I think that is probably one of the things that it's definitely one of the things that I've enjoyed most about my practice. But I also think, when you said in our introduction that like 50% of the people already have heard my name, it's because I have had this ability, and I feel blessed that I was given this ability to just connect with people, whether it's because we both like to fish or if it's because we like to cook some big meal, or whatever,
Yeah.
And I think that's been one of my biggest assets, and it's the part of my job I really like the most now, 25 years later. And I told one of my younger partners this. He was telling me how one day I saw him in the hallway, and I said, hey, how's it going? I got to go to the office this afternoon. And I was thinking, that sounds like fun, And we started chatting, and he's like, I love doing surgery, but I don't like the office so much. And I told him, I said, hey, listen, when I first started out, I hated going to the office. It was like, that was the hard part of the job. It was the not so fun part of it, listening to people complain about this and that and whatever. And the surgery part was always the exciting part. But in the last 10 years, I really have come to enjoy the office hours as much or more than the actual surgery, because, unlike the case we're going to talk about later, a lot of it is just kind of routine. so it's not that exciting anymore. And the office part and meeting new people and connecting with people has become the part that just I've enjoyed the most lately.
You bring up an interesting point, because my responsibility, as the public knows, buying through the radio and what I do in my practice is I align my referrals with strategically and on purpose. I hand select, for lack of a better way to say it, those practitioners, and in this case orthopedic surgeons, that I know that have been vetted out, that kind of check off not just the basic boxes, but all the plus boxes as well too, and then get down to splitting hairs.
Right.
So years ago, and we're going to get, like I said, into this case here, but probably about 10 years ago is when I started using you as kind of like a main referral source. So I said, go see Dr. Tressler, he'll handle you. And people would come back and they give me feedback. It's kind of what everybody does, is how'd it go? And one of the things that they would tell me is this, well, you handled my knee, talked about my knee, but also we got into a nice discussion about hunting, fishing. And he was just a great guy. And my wife was like, are you two going to stop talking about that? And so all of a sudden it's just resonating. Oh, that's great. And so there was this clinical competence there, but also there was this connection. And then what I also, and it's interesting how much can be learned by patient feedback, also asking correct questions, open-ended questions to find out how the visit went, what went on, is what distilled down for me, because I have cases like this one that's coming up. There are problem cases, complex cases, and it just doesn't seem to bother you. Like you said, you're going to do the basic knee, no problem. You'll scope a shoulder, you'll do a rotator cuff repair. And at this point in time in your career, yeah, you've seen thousands of them, and it should be almost kind of monotonous to a degree. Been there, done that, and you can do it with precision. But it's these complex cases that you just don't seem to shy away from, and you take them head on. So that built a confidence both through me when I have to make a referral, but also in a case like this coming up where I'm like, he's going to handle it. And if he can't, he'll figure out where to go. One lady I sent, you couldn't do it. Well, you did one. There's a knee in another case from years ago, and you sent her to Mayo for the other one. But and it's been this kind of nice little mechanism that you have there, which starting from the farm all the way up to where you're at today, and now your career, and like I said, you kind of enjoy the patient experience, which is a really nice transition into our case we're going to study today. And the whole purpose and the reason why I'm here at OSMS, again, this eventually is going to be aired on WIKB. But before we get into the case, I want a general overview from you of, we know knee replacements. I've had some of the other physicians on, but specifically failed knee replacement. What is a failed knee replacement? And describe 2 or 3 main causes.
Okay. Well, a failed knee replacement is really, it's when the outcome of the surgery is less than what was expected or described to the patient. So, if a patient continues to have pain that's nearly comparable to the pain they had prior to the surgery, that, in my mind, is a failed knee replacement. If you look at, say, board test questions in orthopedic surgery, that was always on every board exam or exam that you had to do to renew your board certification. What's the number one mode of failure of knee replacement? And it's changed over my career. So 25 years ago, the number one mode of failure was polyethylene wear, which is essentially the insert that is placed into the knee was made out of plastic that back in the day did not have a lot of science behind it. It was just kind of run-of-the-mill plastic, and the plastic would wear, leaving microscopic particles inside of the knee that the body's immune system would then try to remove from the joint, and in the process of removing the plastic from the joint fluid would lead to resorption of the bone around the implants, and then the implants coming loose and the knee becoming painful, and that was the essential mechanism by which the implants came loose and failed. If you took that same test today and they ask what's the number one mode of failure of knee replacement surgery, it's no longer polyethylene wear. It's now infection. So because of the science that has gone into the research and the development of the implants that we use today, the plastic inserts hardly wear. I've recently seen probably a half dozen people in the last I want to say 3 months, that I replaced their knees 24 years ago when I was getting started, and their x-rays and their implants on the x-rays look like the day we put them in. And it's because of the science that's gone into the development of the polyethylene insert that goes into the knee replacement. So infection is now the leading cause of failure. Usually infection is obvious. Someone has an infection, the knee turns red, they have pain, stiffness, and the only way you can resolve that problem is by getting rid of the infection, which is a big deal. But we see lots of, and I would say that honestly, for me, infection isn't what I see as in my patient population, the number one mode of failure of a knee replacement, because I don't really see many infections, to be honest with you. What I see are implants that are improperly balanced. Okay, so it's a little bit complex, but you have ligaments in your knee, and your knee has a range of motion, and the ligaments need to be in perfect balance throughout the range of motion of the knee in order for the knee to be successful. When people have a knee replacement or a partial knee replacement put in, and the ligaments aren't properly balanced, their knee may be stable and feel right when their leg is in extension, but the minute they start to flex, like if they're going up and down a stair and they have to flex their knee and then use that leg to lift their self up to the next step, or if they try to squat and the knee isn't stable in flexion, the knee will literally nearly dislocate or partially dislocate, which causes a translation between the implants that leads to swelling and pain. And probably that's the number one mode of failed knee replacements that I see, because these patients are coming from outside places where they've had surgery, and I'm not certain, but maybe even the physician that's done the surgery isn't aware that the knee is imbalanced, like from a ligament standpoint, throughout the arc of motion. So it's a little bit of a challenging thing to fix, and I actually have a patient coming up in a week or so that we're going to have to literally take all of the implants out and start from scratch because it's that far out of balance. If it's not terribly out of balance, but there's enough to cause chronic swelling and pain, sometimes you can save some of the parts and modify things, but I would say that that's probably the mode of failure that I see most frequently, or these partial replacements, which we're going to be talking about here shortly. Because I tell patients all the time, there's only maybe one or two very select indications in my mind for use of a partial replacement, and I tell patients all the time, partial replacements solve part of the problem, which is the problem with partial replacements.
Great way to say it. And I'm glad you split that up into two categories. Textbook answer, check off, pass the board.
Yep.
Real life with experience, what's actually happening. Case study by case study by case study, and also the flow of patients that you see as well. And the second part of the answer, and everybody, even the average person with no clinical background, no medical background whatsoever, knows the knee's red hot, it's inflamed, it's infected, most likely, especially if it, other than just being mechanical wear tear problem after a replacement. But it's the second part, which is what's going to be our case study for today, which was a very complex case. This lady, she's a local lady, and I've talked to her, and she's probably going to come on the radio. I'm going to ask her a few questions as well, too. So at some point, hopefully be able to give out her name. But she's a local lady, and you guys would know her. And she had two situations, the first being real bad, and the second being real bad. And she came to me, and I've known her for years. She said, Dr. Larry, I don't know what to do, but I'm not functional anymore. She's retired. She likes to walk. She had a life that she wants to live, and the quality of life was starting to go down. And so out of the gamut of orthopedic surgeons out there, she basically said, open-ended, who? And I said, I've got the guy for you. And this is who you're going to go see. And this case started about 18 months ago. So what I'd like for you to do, Dr. Tressler, is give us the overview of the patient history and presentation as far as this case goes. And then we're going to get into some specific examination and diagnostics utilized for the case, and then we're going to go kind of through this blow by blow.
Okay. Yeah, so she presented to me after she had already undergone a partial knee replacement for osteoarthritis, which was presumably only involving part of her knee. And I think this is where the biggest mistake is made, and where the indications for these partial knee replacements are being they're being stretched. I think also, unfortunately, marketing has become such a huge part of healthcare systems in general. You see people marketing minimally invasive this, outpatient, painless that, come in and have only a partial knee replacement and the recovery's quicker. Okay, so you see doctors that are advertising that they can save your ACL or do just a partial replacement and make your recovery that much better and your knee function more like a normal knee after it's done. And so they're stretching the indications for the use of some of these devices, and this has actually become quite a problem in my practice, because at least, and today was perfect example, I removed a partial knee replacement this morning and replaced it with a total knee replacement. And I believe the patient he suffered for over 5 years, and he's going to do great. Okay, but it's not that easy. It makes the surgery much more challenging, and the outcomes in general, the expectation can't be that it will be just like if it was done with a complete knee replacement the first go around. And this is what happened, unfortunately, for the lady that we're talking about. She underwent a partial knee replacement, and she had, I wouldn't even say moderate, but severe degenerative changes involving more than just one compartment of the knee. So the knee has 3 separate compartments. Partial knee replacements are designed to treat arthritis that's involving only a single compartment. So if you have one compartment of the knee that's terribly arthritic and the other 2 compartments of the knee that are pristine or in perfect condition, theoretically you can do a partial knee replacement and have success. The problem is that that's a rare situation, especially as we get older. If you have a 30-year-old guy who crashes his motorcycle and has a fracture that involves the medial side of the knee joint and the rest of it's fine, there might be the indication down the road to do a partial replacement, and with success. But unfortunately, as we get older, it's a rare situation that degenerative arthritis, or any other type of arthritis for that matter, affects only one compartment of the knee. And then you have surgeons that are sort of stretching the indications, maybe because of advertising that they can get you better faster, etc. And she had, unfortunately, a very poor result with a partial knee replacement that really only solved, and I think actually solved the pain coming from one compartment of her knee, which wasn't the worst of the compartments. So,
and on top of that, you had an additional situation you had to deal with.
Right. So she had terrible arthritis in her patellofemoral compartment, which is the compartment of the knee that involves the kneecap and gives you your strength to go upstairs, get up from a low chair. They did a partial replacement to relieve the arthritic pain coming from her lateral compartment, but she had progression of the arthritis in her patellofemoral compartment because it was not addressed with the surgery, and she ended up falling because her knee gave out and fractured her femur. She had a spiral fracture that went from the distal third of her femur all the way almost to her hip. And now she had a bad situation that was made significantly worse because she had to undergo emergency surgery to have her femur fracture fixed, which entailed placing a rod from her hip all the way to her knee. And her femur wasn't even close to healed when I met her. I think it was actually shortly after the surgery she decided, and maybe you had recommended it, but to come and do her follow-up care after her surgery on her femur fracture with us, and that's when I saw her. So,
yeah, Dr. Brunding said, he told a patient of mine, he says, you ask Dr. Larry to actually just send us maybe an easy patient? I said, no way. No. You're not. I'm not giving you. I'll give you some lobs as well too. But this is one of those situations, folks. As you're listening to Dr. Tressler detail this out, we had a problem on top of a problem. And problem kind of really is a soft way to say it. We have a quality of life issue on a lady that had quality of life, and in a sense, had the right correct surgery been done with the first total knee, with the first surgery, it would have been better outcomes. Okay, so as far as the specific examination, well, patient presentation, just give us a 30-second visual, what she looked like when you first met her. So put yourself into the situation. You've worked hard your whole life, now retired, wanting to stay active, but as it goes with knees, sometimes they wear out. You're going to want to see and have the best surgical option as it relates to your knee, not your neighbor's knee, not your coworker's knee, your knee. Well, what happens if that surgical indication and option that was used is not correct, and now that knee of yours is worse? You need to know why and who can fix it. So after having been in practice for now 20 years, I run into many cases where a patient is left in a lurch. And in our local lady's case, that's exactly what happened. Part 2 of my interview with Dr. Tressler is coming up next week. We had a lot of content to get through and not enough time this week, but lo and behold, we always have next Thursday at 12 o'clock. And by the end of the show next week, you're going to hear from the actual patient. What happened with the first surgery, the first surgeon, and how Dr. Tressler, as he's done many times over his career, gave her quality of life back. All of that packed next week.